Most of these injuries that we see will be on the cornea, and that is the rust ring as well. Right behind the cornea, you have the iris. Right behind the iris is the pupil, and then you have the lens. Your deeper structures will be your retina, blood vessels, uh, fovea, and macula. Typically, patients, when they come in, they're coming in for a reason, right? So some of these symptoms can be pain, blurred vision, tearing, visible foreign body sensation, or erythema or redness. So immediately when you walk in the room, there are some things you will notice about this patient. Remember, what one eye does, the other eye will automatically do. So if a patient is having any photophobia or blurred vision, the light reflex, usually their eyes are covered because it not only affects the eye that they've injured, it also affects the other eye. So these patients will sometimes have their eyes covered. They'll wear sunglasses. They'll already dim the lights before you go in the room. So just be mindful that light may bother them as well. On your history and present illness. So this is where you got to really capture some important things to know that this is appropriate to do. So we want to know the onset of symptoms. Typically, these people come in pretty quick. We like them to come in within hours after the injury happened, but a lot of times 24 to 48, maybe 72 is the max that they're presenting to your facility. History of eye surgery, injections, procedures. You want to know before you start bothering the eye. Do they have a lens? Did they have some kind of implant in there? Use of contact lenses or glasses. Contact lenses, especially because as a prescriber, you have to prescribe differently because the organism that typically will affect the eye of a contact lens wearer is different from those who do not wear contact lenses. The last eye exam, the mechanism of injury, and the precipitating details. Were they walking? Were they outside? Was water involved? Was something flying around? Did something actually puncture the eye? Mechanism of injury. A lawnmower. Did it come off the lawnmower? You really got to dig in sometimes and ask those right questions. What does your physical exam look like? So your extraocular motion is intact. Perla, pupils equal, round, reactive, and accommodates to light. Do you see any irregularity in the pupils? Keratoconus, that's very important. The best way to assess this is to actually look from the lateral sides and you'll see a protrusion of that eyeball. Visual acuity. Always, as soon as the patient is able to tolerate your anesthetic, and you likely will have to put at least one drop of either tetracaine or proparacaine, which are your ophthalmic anesthetics, in before the visual acuity can be done. Any drainage. Do you see a flow of drainage? Is it just watering? Is it irritated? Please be mindful. A constant flow, especially with a precipitating event like something flew in my eye off a lawnmower, should raise your suspicion that it may be more than the cornea that has an injury. Periorbital assessment. Do you see redness? Are there lacerations within the orbital brim? Do they have bruising, lesions, abrasions? And of course, what is your Woods lamp examination findings? So for the rust ring, commonly caused by a metallic foreign body, this usually will develop because of oxidation of iron of that foreign body. A small rust ring produces little visual difficulty typically. Sometimes it can be in the direct line of sight, but if it is really large, it can really delay corneal healing. So it is uncommon for a person to say that they have any kind of peripheral vision loss or vision loss. They may notice that it's something in their line of vision, but it should not be vision loss associated with this. The rust ring can definitely cause it to come. The rust ring can cause ulceration, and that's when it has settled a little bit and become more embedded in your cornea. The goal is healing of the cornea and total removal of the rust ring and the foreign body. More so, the foreign body has to be removed. The rust ring, you want to try to achieve complete removal of it. But just remember, the rust ring by itself can actually be followed up with the ophthalmologist as well after you have made a few attempts to remove it. Now, the Woods lamp exam. There are several different kinds of Woods lamp that you may see in your facility. These two that you see are typically common ones that you see. One is a handheld, and one is it's handheld as well, but it has the magnifier that you can look in. You want to gather your supplies, so you need gloves, you need your ophthalmic anesthetic, a fluorescein strip, cotton tip swab. You want a 25 to 30 gauge needle with a syringe, saline for irrigation, and of course your Woods lamp. When you look at the Woods lamp, so you have a couple of lights as switch that can turn the light from a bright light to the cobalt blue, which will help illuminate any abrasions or foreign bodies on the eye. This is super important. You want to dim the lights and make sure that this works before we start the procedure. For the Woods lamp examination, you want to sit the patient in the upright position and drop 1 to 2 drops of the anesthetic drop in the eye. It is easier for you to have the patient hold the bottom of the eye and you kind of open the top lid. If the patient is very light sensitive, you got to be really quick. So I would have them chin up and tilt the head back, and you want to drop it somewhere on the eyeball. Typically have them look in an outer direction or in the opposite direction of where you're going to place the drops. Once the eye is anesthetized, place 1 to 2 drops of the anesthetic onto the fluorescein strip and then touch that moistened strip to the anesthetized eye and have the patient blink several times, moving the eye side to side to distribute the stain all through the eye. Then you want to dim the lights. You change your light source to the cobalt blue and focus on the superficial portion of the cornea. Look for any uptake of that fluorescein. Sometimes you may have to have them blink a few times so you can clear the fluorescein. If it rolls right back off, that is not indicative of an abrasion or a foreign body. However, if it collects, you will clearly be able to see it. Uptake on the stain in a linear distribution is indicative of a corneal abrasion when the ulcers are usually round and crater-like in appearance. The rust ring. So if you look at our arrow, it kind of points out exactly what the rust ring looks like. It is usually visible to the naked eye, and the Woods lamp examination helps to further assess the eye disorder. So we clearly see there's a rust ring, but can you clearly see a foreign body? Sometimes you can, just depending on if it's a metal fleck, depending on the type of foreign body. Typically metallic will show up very easy, but if it is a piece of wood shaving or plastic shaving, you may not be able to clearly see that is the foreign body. Your rust ring treatments, and these are topical antibiotics. You have brand name and generics and the dose. And so when you look at topical antibiotics, some of your typical ones are listed. You want to know, GoodRx is a good app to get on, especially for your cash pay patients, because it's very important that you know which ones are reasonable and affordable and which ones are expensive. Ear and eye drops can be pretty expensive for the patient. When we talk about knowing the appropriate ophthalmic antibiotics, we class people into people who wear contact lenses and individuals who do not. And as you can see, Pseudomonas is the organism that is responsible for the infections of the individuals who wear contact lenses. So listed below, as you can see, you have your fluocinolones are your major classes, and then tobramycin and gentamicin is listed as well. Your topical NSAIDs will help with pain. Just be mindful that some of these can be very expensive and typically require a prior authorization. So a lot of times in the urgent care and emergency room, we elect for oral NSAIDs and maybe even low dose opiates to help control pain. When you actually remove the rust ring, there's two steps. So you can take a soft tip Q-tip, and also a pearl of wisdom to take with you is you can drop an anesthetic drop onto this Q-tip and gently stroke the eye several times to try to get the foreign body to remove it. Each time you stroke, actually visibly look at the Q-tip to see if it's removed. Portions of the rust ring may still be present, and at this time, you can take a needle, that 20 to 25 to 30 gauge needle, and actually attempt to remove the foreign body. Just very gentle, very superficial, and you definitely need a steady hand. Hot tips or pearls? Cycloplegic should be prescribed by ophthalmology. We don't prescribe them. Patients will come in, especially your welders, and say, I have used these before, they work better. But typically, we will stick to the topical antibiotics, the topical NSAIDs, and oral pain medicine, and let ophthalmology prescribe the cycloplegics and even the steroid base. Ointments are preferred rather than drops, as they lubricate and have some protective functions. Aminoglycosides can be toxic to the corneal epithelium and should be avoided, except as an alternative in abrasions associated with recent contact lens wearers, and if a topical fluocinolone is not available and cannot be used. Rarely, but be aware that sulfonamides is associated with severe allergic reactions, including Stevens-Johnson. So make sure this is your last resort. And if you are going to prescribe this, they need an ophthalmology appointment, like within 2 to 3 days. And a lot of times this is the last resort and allergies are the problem. Just be mindful that you don't have the same sensitivity with topicals as you have oral. So if a patient is allergic to sulfur, they still may be able to tolerate Polytrim, which is sulfur-based as well. Topical preparations containing steroids, again, should be avoided. Now, rust rings. When do we refer to the ED? If you see evidence of an open globe, traumatic hyphema, intraocular foreign bodies, penetrating eye trauma, chemicals in thermal burns, double vision, pain out of proportion, and previous eye surgery with implants or lenses. Please use some caution when you see these. Also, we get a lot of these with nail glue. Like people were trying to glue their nail, and all of a sudden, some of the glue was placed in the eye either by the finger or they accidentally touched the eye. If there is a very small portion, yes, a gentle removal with the same technique you use for the rust ring is appropriate. However, if there is a large amount or the eyelid is involved at all, they need ophthalmology to do this. Patient education. Do not rub or scratch the eye. Typically, what you see under that Woods lamp is a motion where you see that patient has instantly started scratching or rubbing the eye after the foreign body got into the eye. Advise the patient that pain may return when the anesthetic wears off and they need glasses and UV protection. Do not wear contacts until cleared by ophthalmology. NSAIDs are helpful for pain control, but please consider low-dose opiates because this is a very painful injury that can occur. Do not use an eye patch. We do not patch anymore. They can just simply close their eyes, dim the lights, definitely limit stimulation. Practice frequent effective hand washing. Encourage the patient not to touch the eye at all. Encourage compliance with the topical antibiotics. Stress the importance of follow-up. If they have a rust ring, follow-up is super important because you want to make sure that they do not turn into ulceration. And of course, protect the eyes from sunlight exposure, and they should wear sunglasses. Hot tips and pearls of wisdom. Do not cause more damage when attempting to remove the rust ring. Know when to refer. After a couple of attempts, if you have not completely removed it, at this point, You have to stop. You don't want to continue and then call a friend to try as well. After you, the foreign body is the priority, and then as much of the rust ring as possible. The eyelid should always be inverted and fully inspected. Removal of a rust ring is not an emergency. Ophthalmology follow-up is required. If left in place, the rust ring will become soft and come out in one piece. High-speed metal welding, grinding in the presentation of a foreign body cessation demands ocular imaging to rule out intraocular foreign body. And just remember, eyes move in sync. One eye should not be going left and the other eye go right. They should move in sync. All right, that concludes our presentation. Our contact information is listed, website, email, and our customer service number. I hope you enjoyed this presentation. Have a good day.